Good evening, everyone. Let us begin today's session with Omkaram. Now, let us follow with the NMO mantra. Natvaham kamaye rajyam, na swargam na punarbhavam, kamaye dukkha taptanam, praninamurti nashanam. A warm and heartfelt welcome to all the participants of NMO AP's Med-Katalyst Foundation Revision Series. Today is the day 4 of our 15-day Rapid Revision Series, an initiative aimed at strengthening the fundamentals of first-year medical students. It is our privilege to have Dr. P. Srinivas Rao, Sir, Professor of Department of Physiology, GSL Rajahmundry, with us today. We sincerely thank you for graciously accepting our invitation, sir. Sir, we'll be discussing renal and CVS physiology today. With great respect, I now request Dr. P. Srinivas Rao, sir, to kindly take over the session and guide us with his valuable insights.
Okay. First, I thank NMO for coming up with this wonderful series of revision and giving me this opportunity of taking part in this. So as you all know, this is going to be a revision class. It's not going to be a theory class like thing. And I'll be trying to tell what is also important as an MCQ, which will come to you as an MCQ. And if at all a question comes, how to answer it. That will be the way in which I'll be teaching today, because the basics is known to everyone. So first I'll be talking about the glomerular filtration rate, then I'll be talking about the cardiac output, and in the end we'll be talking about the short-term regulation of blood pressure. All three can come as a essay question, or it can come as a short notes, 5 marks. So as you all know, glomerular filtration rate, anywhere in medicine, if rate comes, it is per minute, except in one place. Anyone can tell me what it is? Erythrocyte sedimentation rate is the only place in medicine where rate means in the first hour. Otherwise, heart rate, respiratory rate, glomerular filtration rate, everywhere it is per minute. So glomerular filtration rate is the volume of plasma which is filtered by the glomeruli per minute. So normally 125 ml per minute, 180 liters per day. This you have to by heart. This can be asked as a Viva question, it can be asked as an MCQ question, or it can be asked everywhere. In the practicals it can be asked. So you have to by heart these numbers. Normal GFR is 125 ml per minute in a normal average adult. That comes to about 180 liters per day. Now you'll be having a doubt. What is this? 180 liters per day is getting filtered. Why are we not urinating so much? So most of the filter substance is reabsorbed. That's why we only have a small amount of urine which is coming out. But remember, glomerular filtration rate, the rate of filtration is 125 ml per minute. And it is the single best index of overall kidney function. So it is essential when you are talking about how to give the drugs or a chronic kidney disease and all. So, we have eGFR also. So glomerular filtration rate is the best index of overall kidney function. This is also an MCQ. Now we'll come to the filtration barrier. The barrier which helps and which prevents the larger substances from getting filtered. So there are three. I request all of you to take a pen and a pencil or a pen and a book and write it in short terms. Otherwise, you'll be hearing it. It will be nice, but then finally, after the entire class is over, you will not remember anything. So I request all of you to keep a book and have a pencil or a pen. You can put a filtration barrier and put 3 arrows. Fenestrated endothelium, that means the endothelium of the blood vessel will be having pores, that is small gaps. Then you have the glomerular basement membrane. What does this contain? Type 4 collagen and heparin sulfate. This is an MCQ. What does the glomerular basement membrane have? Type 4 collagen and heparin sulfate. What is the importance of this? This will provide a charge. That means it will prevent anion proteins like albumin from going through the filtrate. So it will not allow the proteins like albumin to go into the Bowman's capsule. So this you have to remember. If you find a large amount of albumin inside the urine, that means that this filtration is not taking place properly. That's why in a normal urine, albumin is not present. And the third one is the podocyte and slit diaphragm. Podocyte is food processes. The legs, the cells which look like legs, they are called food processes. They form a filtration slit. Nephrin and podosin proteins maintain the size selectively. So this is also an MCQ for NEET. Nephrin and podosin proteins maintain size selectively. Because I was told that not only the first years, but some other people are also coming. So I added a few things like this. So what are the three things? A fenestrated endothelium, which is present in the blood vessel, the glomerular basement membrane, which has type 4 collagen and heparin sulfate. What is the importance of this? It provides selectively charge, where the anion proteins will not be able to go through the filter. Then you have podocytes and slit diaphragm. And what are the proteins? Nephrin and podosin, which is the final barrier for filtration. Now, this will come as a 3-mark question, or it can come as a 5-mark question. This can come even when the edema also takes. There also the same forces will be taking place. So what are these Starling forces? Starling forces are the forces which help and prevent the filtration. That means some forces will help in the filtration process. Some will not be helping it. They will be preventing the filtration. So what are they? One is the hydrostatic pressure, which is present in the capillaries. This pressure normally is about 60 millimeters of mercury, will be allowing the filtration to form. That means it will be pushing the fluid towards the filter. That means whenever there is an increase in the glomerular capillaries, there is an increase in the filtration. In the glomerular capillaries also, I told you, you have albumin. I also told you albumin is not filtered. It is prevented from filtration because of the positive charge. So this glomerular capillaries, which has this oncotic pressure, will oppose the filtration. So in the glomerular capillaries, you have two forces. One which favors the filtration, one which opposes the filtration. What is that which favors the filtration? The hydrostatic pressure in the glomerular capillaries, which is normally 60 millimeters of mercury. Then what is that which prevents the or opposes the filtration? That is the oncotic pressure. What do you mean by oncotic pressure? The pressure exerted by the albumin, which is present in the fluid. So that is about 32 millimeters of mercury. Then you have the Bowman's capsule. You can see there, the Bowman's capsule also will be exerting some pressure. This will be opposing the filtration. So one more thing which is opposing the filtration is the Bowman's capsule hydrostatic pressure. See, in the Bowman's capsule, you don't have oncotic pressure. Why? Because I told you the albumin is not filtered. So the filtrate will not be having albumin. So there will not be any oncotic pressure in the Bowman's capsule. So what are the most important pressures? That's why it is negligible. So what are the three pressures? The hydrostatic pressure in the glomerular capillary, 60 millimeters of mercury, which favors filtration. Then the oncotic pressure in the glomerular capillaries, which opposes the filtration, normally 32. So the net filtration pressure, if you see, 60 minus 18, because that is opposing the filtration, minus 32, that is equal to 10 millimeters of mercury. So what is the net filtration pressure if they ask? That is 10 millimeters of mercury. This can be given as a problem in your practicals also. So you have to remember this. These numbers are very important. Then what are the determinants of glomerular filtration rate? So the first one, big K and small f, that is the filtration coefficient. So all the filtration, every person will be having a filtration coefficient. What is this made of? This filtration coefficient is made up of the surface area or the number of glomeruli which are taking place in then the thickness of the membrane. All this also, in addition to the other factors, will be having a role to play. So KF means it is the area of the which it has to undergo, thickness, and net filtration pressure. I told you about the net filtration pressure of 10 millimeters of mercury. We have you got. So glomerular capillary pressure, increase in the glomerular capillary pressure causes what? The glomerular filtration, increase in the glomerular filtration rate. Bowman's capsule pressure. When does this increase? Suppose there is an obstruction to the kidney by a stone. This stone will be obstructing the outflow. So when it is obstructing the outflow, it will be causing an increase in the pressure of the Bowman's capsule. So I told you, whenever there is an increase in the Bowman's capsule pressure, there is a decrease in the GFR. Then the oncotic pressure. Whenever there is an increase in the oncotic pressure in the glomerular capillaries, there is a decrease in the GFR. I told you why? Because the oncotic pressure will oppose the filtration. So whenever there is an increase in the oncotic pressure, it will oppose filtration. For example, when you have burns, there will be an increase in the oncotic pressure, which causes a decrease in the GFR. So how is GFR regulated? So now you know what is glomerular filtration rate definition. Then you know about the membrane, filtration membrane, what all it is made up of. Then you know about the Starling forces, the forces which help or prevent both the filtration. Now we come about the regulation of the glomerular filtration rate. So they will ask you all this in the essay question, also in the 5-mark question. By three methods: auto-regulation, neural control, hormonal control. So you can write down GFR regulation and put 3 arrows: auto-regulation, neural control, hormonal control. And in auto-regulation, you can put 2 more arrows again: myogenic reflex and tubuloglomerular feedback mechanism. Auto-regulation is again of 2 types. Put 2 arrows: myogenic reflex and tubuloglomerular feedback mechanism. I'll be talking about that later on. See, normally GFR is constant between a mean arterial pressure of 80 to 180 millimeters of mercury because of these two. I'll be telling how. Okay. So though it is 84 or though it is 174, I told you if there is an increase in the blood pressure, there is an increase in the GFR. But in this range, there will not be any increase because of the auto-regulation. Then neural control. Mostly it is because of the sympathetic stimulation. I'll be telling it to you later on. And finally, you have the hormonal control. So remember, GFR regulation, 3 ways: auto-regulation, neural control, hormonal control. Auto-regulation is again of 2 types: myogenic reflex, tubuloglomerular feedback mechanism. Neural control is by sympathetic stimulation. Hormonal control is by angiotensin 2. I'll be talking about that later on. See, I think all of you know that the glomerulus will be having one afferent arteriole and one efferent arteriole. Afferent arteriole means the arteriole in which the blood is coming into the glomerulus. That is going to divide into the capillaries. And then you have the efferent, that means from which the blood is coming out. So afferent means the blood is coming in, efferent means the blood is coming out. In between, you have the capillaries. You have to remember this because the regulation is very important when the afferent dilates or the efferent dilates. I'll be telling it now. So now come to the first one: auto-regulation, myogenic mechanism. Whenever there is an increase in the blood pressure, there is a stretch of the smooth muscle wall. Whenever there is an increase in the blood pressure, there is a stretch of the smooth muscle wall. When the stretch happens, what happens? Stretch activated calcium channels open. I think you know there are different calcium channels, and the ligands could be stretch, or it could be voltage gated, or it could be in some places chemical gated. Calcium channels are there. I think you know that in the neuromuscular junction you have voltage gated calcium channels, but here it is stretch activated calcium channels. So whenever there is a stretch, these calcium channels will open. When the calcium channels open, the smooth muscle will contract. It causes vasoconstriction. See, in the neuromuscular junction, whenever the calcium channel opened, they used to push the acetylcholine to the neuromuscular junction, which used to cause the muscle to contract, isn't it? Same thing happens here, but here it is the smooth muscle, vasoconstriction. So when this vasoconstriction happens, the glomerular capillary pressure is stabilized. The GFR is maintained despite the systemic BP changes. So this, I told you, happens from 80 to 180 millimeters of mercury. Suppose it becomes 100, there is a stretch. That stretch will cause the calcium channels to open. This calcium channels will cause the smooth muscles to contract. When it contracts, the flow will reduce. So when the flow reduces, the BP also comes down. So this is called the myogenic mechanism. Then the tubulo-glomerular feedback. So what is this feedback? This is also a feedback for autoregulation. I told you autoregulation has two. One was the myogenic, second one was the tubulo-glomerular feedback. When the GFR increases, so you can see here, number one, when there is a GFR which increased, that means the glomerular filtration rate has increased. So what will happen? The flow through this tubule will increase. So the loop of Henle will come and it will come to the JJ apparatus. So it flows past the macula densa increases. That means because the filtration has increased, the flow also increases. When the flow increases, the macula densa will produce some substances which will cause the constriction of the afferent arteriole. So you can see here, this is the afferent arteriole. Afferent means this is coming, the blood is coming inside. So when this blood is coming inside, it is coming in contact with the substance which will cause the constriction. And I told you, if there is a constriction of the afferent arteriole, what will happen to the blood which is coming into the capillaries? It is going to reduce. So when there is a decrease, the GFR will decrease. Hope you can understand this. So in the beginning, what happened? There is an increase in the filtration. When there is an increase in the filtration, there was an increase in the flow in the glomerulus and from there into the tubes. And from there, it came to the juxtaglomerular apparatus where the macula densa senses this increased flow and will produce substances which will cause the constriction of the afferent arteriole. When the afferent arteriole is constricted, the flow will reduce. So when the flow reduces, the blood flow reduces, there is a decrease in the GFR. So this is the tubulo-glomerular feedback. Sometimes only tubulo-glomerular feedback is asked as a 3-mark question. Remember that. Then neural regulation of GFR. I told you about sympathetic control of GFR. So sympathetic means adrenaline, noradrenaline. Sympathetic nerves are T8 to L1. So innervate the renal vasculature. So this is also MCQ. T8 to L1 innervate the renal vasculature. Norepinephrine causes more afferent than efferent arteriole constriction. So remember, norepinephrine can cause a constriction of both the afferent as well as efferent. But the afferent is constricted more than the efferent. That means the blood flow which is coming inside the blood vessel is constricted more. So now tell me, what will happen if the afferent is constricted more? Does the renal blood flow increase or decrease? The renal blood flow decreases. Because there is a decrease in the renal blood flow, there is a decrease in the GFR. See, if you have any doubt, because I cannot see the chat box here, you can ask me in the end. Okay, you note it down. You can ask me in the end. Okay, yeah. During the fight or flight, same thing. Sympathetic activation, renal blood flow is diverted to muscles. See, when you want to run, what will happen? The sympathetic is activated. When the sympathetic is activated, all the important organs will be dilated. For example, what will happen to the iris? It will dilate. What will happen to the bronchus? It will dilate because you need more amount of air. This also stimulates the renin release, which activates the renin-angiotensin-aldosterone system, further which decreases the GFR. This causes vasoconstriction. So this flight and fight reaction, what does it do? It diverts the renal blood flow to the muscles because the muscles require more amount of blood. It also stimulates the renin release. I'll be talking about this in the next slide. Activates the renin, angiotensin, aldosterone system. RAS system can be asked in CVS. It can be asked in renal also. Remember, it can be asked in hormones also. So it is important for both paper 1 as well as paper 2. So renin, angiotensin, aldosterone system. So you can see here, the liver will produce a substance called angiotensinogen. So remember, angiotensinogen is produced by the liver. This is an MCQ. Okay. Renin is produced by the kidney. What does renin do? Renin will convert this angiotensinogen to angiotensin 1. Okay. From where is the angiotensinogen produced? The angiotensinogen is produced from the liver. From the liver, it is converted to angiotensin 1 by renin, which is released from the kidney. What will release the renin? It is triggered by the low BP. Whenever there is a low BP or a low sodium or a sympathetic nervous system activation, all this will cause the formation of renin. What are the three things? Low BP can cause the production of renin by the kidney. Low sodium in the blood can cause the activation of renin. Then sympathetic nervous system activation can cause the release of renin. What does this renin do? It converts the angiotensinogen to angiotensin 1. What does angiotensin 1 do? Angiotensin 1 is converted to angiotensin 2 by the angiotensin converting enzyme, which is released by the lung. So this you remember. Lung will be producing the angiotensin converting enzymes. Renin is produced in the kidney. Angiotensinogen is produced in the liver. So that's how it maintains the GFR. What does aldosterone do? Aldosterone promotes the sodium and water reabsorption. So this helps in getting back the normal BP. Then other hormonal regulators, ANP, that is the released by the atria, atrial natriuretic peptide. It causes vasodilatation of the afferent arterioles and constricts the efferent. So remember, dilatation of the afferent arteriole increases the blood flow. Constriction of the efferent arteriole more than the afferent will also increase the GFR. So blood flow is increased, resistance by the efferent arteriole is increased, which increases GFR. Then prostaglandins E2 and I2 will cause vasodilatation. So remember, non-steroidal anti-inflammatory drugs like Brufen, then all the painkillers block this. They reduce GFR. But I have seen so many students taking painkillers like chocolates. Every day they are taking the painkillers. Remember, this will cause a problem with your kidneys. You have to tell your patients also not to keep on taking the painkillers. For simple pains also, you are taking painkillers. You can take paracetamol for a painkiller because that is excreted by the liver. But don't try to take all these anti-inflammatory drugs because they cause a decrease in the GFR and the persons may land up with kidney failure. Then nitric oxide, it is produced by the endothelium. Vasodilatation of the afferent arteriole will increase the renal blood flow, increases GFR. All three act as protective modulators of GFR. So ANP, prostaglandins, nitric oxide. All these three will cause a dilatation of the afferent arteriole and it constricts the efferent arteriole. So these are the methods in which the GFR is regulated. Measurement, inulin clearance. This formula also you have to remember because this is given in the practical examination. GFR is equal to the quantity in the urine by V by P. Then creatinine clearance, eGFR, which I was telling you, is also a way of measuring GFR. I am not talking this in detail because this will be told in biochemistry. Okay. Chronic kidney disease, staging by GFR, stage 1 to 5. Stage 1 is when the GFR is more than 90 but less than 60. Stage 2 is GFR 60 to 89. Stage 3 is again divided into A and B. This is not very important for you. But if you write the chronic kidney disease has 5 stages, it will add 1 mark more. Understood? In the GFR question, if it is asked, you just write about the chronic kidney disease where the GFR is reduced, and when the GFR is reduced so much, it will cause the staging of the. So that is about the glomerular filtration rate. If you have any doubts, you can please ask me after the end of the class. Or do you want to take the questions now?
Sir, at the moment there is no response from the students, sir. I guess last lo adutar anukunta, sir.
Okay. So shall I carry again? Carry forward?
Yeah, sir.
Okay. So now we come to another essay question. And Frank-Starling law can be asked as a short notes. So don't get confused with this Starling and that Starling. Understood? That Starling was the forces which cause the fluid to go out of the blood vessel. So it can be used in filtration. It also can be used for formation of edema. See, when the albumin is reduced, as you see in kidney failure, or when the albumin is reduced, when the liver cannot be forming the proteins, then also you have edema, isn't it? Though that is because the oncotic pressure is reduced. What do you mean by oncotic pressure? Oncotic pressure is the pressure which is exerted by the proteins of the blood, which prevent the fluid from going out, which prevent the fluid from going out. So now we come to the cardiac output and Frank-Starling law. Cardiac output. See, in the exam, many of you, what you are telling, when we ask what is cardiac output, you are telling heart rate into stroke volume. That is wrong. You should not tell like that. Heart rate into stroke volume is the formula for determining the cardiac output. But when the definition of cardiac output is asked, you have to tell cardiac output is the volume of blood pumped by each ventricle per minute. So remember that. The cardiac output is the volume of blood pumped by each ventricle per minute. So the left ventricle and the right ventricle will be pumping out the same amount of blood. One will be going to the tissues, one will be going to the lungs. So cardiac output, when it is asked, what is cardiac output? Don't say heart rate into stroke volume. You tell that is the formula. Normal cardiac output is in the same way when someone asks you what is ECG, you will tell ECG means electrocardiogram. You are not supposed to tell only the expansion, isn't it? You have to tell that it is the graphical representation of the electrical activity of the heart recorded from the surface of the body. This is the definition of ECG. So definition is different. The abbreviation is different. The formula is different. Understood? So when they ask you what is cardiac output, you are supposed to give the definition. Okay. Yeah. 4 to 8 liters, average about 5 liters. Normal heart rate is 72 beats per minute. See this also in the exam. Remember, if someone asks you what is the normal heart rate, don't say 72 per minute. Understood? That is there, okay, in your intermediate. But you have to tell 60 to 100 beats per minute. So write down. If someone asks you what is the heart rate, don't tell 72 beats per minute. Say 60 to 100 beats per minute. Because if it is below 60, it is called bradycardia. If it is above 100, it is called tachycardia. So someone asks you in medicine, what is the normal heart rate? You have to tell 60 to 100. This 72 beats per minute, how you got, because we tell that diastole is 0.5 and systole is 0.3. When you add that, it comes to 0.8. So per minute means 60 seconds. 60 by 0.8 is equal to 72. That's how you got that 72. But don't tell that as the normal heart rate in medicine. You have to tell 60 to 100 beats per minute. Normal stroke volume. What do you mean by stroke volume? The amount of blood which is coming out per each beat. Okay. Every time the heart contracts, when the heart goes into systole, some amount of blood is going into the tissues. It is going to go out through the aorta. So that will be 70 ml per beat. Then what is cardiac index? Cardiac index is cardiac output divided by the body surface area. Okay, divided by the body surface area. So normal cardiac index is 2.4 to 4 liters per minute. What is the clinical significance of the cardiac output? Reflects the cardiac performance and tissue perfusion. See, many a time when the cardiac output reduces, the tissue perfusion reduces. The patient goes into shock. So whenever they ask you and tell you what is shock, shock means it is circulatory shock. Remember that. Whenever it is given in physiology, shock, that means it is circulatory shock. Don't write whatever you want. You have to write what are the 4 causes of the shock. What are the 4 causes which reduces the cardiac output. That you have to write. Okay. And remember, shock can be given as a clinical case also. Cardiac output and regulation can be given as a short notes, but shock can be given as a clinical case. Generally, hypovolemic shock is given. So you have to be thorough with hypovolemic shock. What are the factors affecting the cardiac output? So I told you that's the formula, heart rate into stroke volume. So heart rate, I think you all know. How is it the heart rate regulated? It is regulated by the sympathetic, parasympathetic, and also by the preload and afterload. So what is preload? Preload is the end diastolic volume. So what is end diastolic volume? When the heart, before it contracts, the volume of blood which is present before systole, that means at the end of diastole. So what is the preload? The preload is the amount of blood which is present at the end of diastole inside the ventricle. So what does this depend upon? It depends upon the venous return. What do you mean by venous return? The amount of blood which is coming through the superior and inferior vena cava into the right ventricle. Okay, that is the venous return. Okay, so whenever there is an increase in the venous return, it causes an increase in the stroke volume. This is the Frank-Starling law. I will be talking about the Frank-Starling law later on. But remember the words preload, afterload. So whenever the question cardiac output is asked, you have to write these 2 words, preload, afterload. What is preload? It is the end diastolic volume. What is afterload? The resistance of the ventricle which it has to undergo to send the blood out. For example, the heart is contracting in systole. So the blood is going out through the aorta. When the blood is going out through the aorta, suppose the aorta is having an increase in the pressure, either because of hypertension or suppose there is a constriction of the orifice of the aorta. Suppose there is aortic stenosis. So what will happen? The blood has to go against more resistance. So less amount of blood will be going. So the stroke volume will reduce. So when the preload increases up to a certain extent, the stroke volume will increase. I'll tell you why in Frank-Starling law. Whereas the afterload, when the resistance the vertical overcomes increases, TPR means total peripheral resistance. The stroke volume will reduce. The third thing which is important is contractility, inotropy. That means the heart, if it is strong, if it is healthy, then it will be able to contract properly. So if it is diseased, it will not be able to contract properly. So inotropy, that is called inotropy. I think you all know inotropy. What is inotropy? What is bromotropy? What is chronotropy? All that you have to know. Okay. Inotropy is contractility. Intrinsic myocardial force is called inotropy. That is increased by catecholamines, and whenever there is a decrease in the calcium by acidosis, hypoxia, all this will cause an increase in the inotropy. Whereas decrease in the inotropy is caused by acidosis and hypoxia. So preload, definition. Preload is the degree of stretch of ventricular muscle fibers at the end of diastole. This is what I told you just before the systole, just before contraction. What does it reflect? It reflects the volume of blood in the ventricles. That is the end diastolic volume. Okay. So what does this end diastolic volume do? It gives a pressure which is called the end diastolic pressure. So how did this happen? Some amount of blood was coming from the atrium into the ventricles. and the ventricles went into diastole. When the diastole is ending and the systole is about to begin, there is some amount of blood in the ventricle. This blood which is present at the end of diastole, this volume of blood which is present at the end of diastole is called end diastolic volume. So what does end diastolic volume determine? End diastolic volume will determine the preload. So end diastolic volume determines the preload. So preload is because of what? Venous return. So venous return, blood volume, venous tone, body position, atrial contraction. I think you all know the how the atria contracts in the end. 20% of the end diastolic volume is from the atria. That's why this will not happen in atrial fibrillation. What is atrial fibrillation? The atria will not be contracting properly. It will be fibrillating. That means it will be only shivering. It will not be contracting. So when it is shivering, what will happen is this last part, which is coming into the ventricle, will not happen. That's why there is some amount of clot. So that is important for the people who are studying medicine. But remember here, so end diastolic volume also depends upon the venous return, the amount of blood in the, suppose the person is having hemorrhage, so much of blood has gone out, then the blood volume will reduce. So end diastolic volume also will reduce. Then venous tone. Suppose the patient is having less tone, that means the blood is stored inside the venous. For example, in anaphylactic shock, there is a vasodilatation. In anaphylactic shock, there is vasodilatation. What do you mean by vasodilatation? Not only the arteries are dilated, the veins are also dilated. When the veins are dilated, what will happen to the blood? It will work as a storehouse for the blood. So the amount of blood in the arteries will be less. Why is it less in the arteries? Because it is being stored in the veins. See, normally there is a tone for the venules. This tone is by the sympathetic activity. Whenever there is a shock, for example, a person is in septic shock, the venous tone is lost. So when the venous tone is, or an anaphylactic shock, any shock where there is a dilatation of the, this is called warm shock, the venous tone is lost. Then body position and atrial contraction. So atrial kick adds 20% of end diastolic volume. This is an MCQ. Understood? That atrial contraction which happens in the end, just before the systole, it gives 20% of the end diastolic volume. Now we come to the Frank-Starling principle. So what does Frank-Starling law says? Within physiological limits. This word is important. You write down. Within physiological limits. Frank-Starling's law, Frank-Starling principle are all useful only within physiological limits. If they cross the physiological limits, they will not be acting according to this principle. So what does this principle say? Whenever there is an increase in the preload, so what is preload? The amount of blood which is coming into the heart. There is an increase in the end diastolic volume. When there is an increase in the end diastolic volume, there is a stretch of the atria, isn't it? When the ventricles. End diastolic volume stretches the sarcomere of the heart. When there is a stretch, there is an optimum actin-myosin overlap. Understood? Within physiological limits, when this happens, this end diastolic volume will cause a sarcomere stretch, which causes that nice balance between the actin and myosin overlap. This will cause an increase in the force of contraction, which causes an increase in the stroke volume. For you to understand this principle, imagine that you are having a rubber band in your hand. Rubber band, when you pull for a certain length, what will happen? It will contract very, very fast. But suppose you keep on pulling, it will break, isn't it? So as long as it is not broken, the rubber band will follow the Frank-Starling's law. What does it mean? Within physiological limits, the stretch will cause a very fast contraction. So here, why does it happen? Whenever there is a preload and there is an increase in the end diastolic volume, the sarcomere stretches, which causes an increase in the actin-myosin overlap, which causes an increase in the force of contraction. And because the force of contraction is high, there is an increase in the stroke volume. What is the normal stroke volume I told you? 70 ml per beat. Remember that, 70 ml per beat. This is the cellular basis of Frank-Starling law. See, many of you, though it is given for 3 marks, if they ask you Frank-Starling's law, you are writing only the law and reading everything behind. That should not happen. You should write the law. That's also good. But you'll get only half a mark. You have to write the reason for the Frank-Starling principle. What is its clinical relevance? So why is it important? In heart failure, okay? In heart failure, what will happen? There is an increase in the end-diastolic volume. Here also, there is an increase in the end-diastolic volume. There is an increase in the preload. But what is happening? Because of the failure of the heart, there is ventricular dilatation. Understood? There what happened? Whenever there was an increase in the end-diastolic volume, it was within physiological limits. So what it did, it causes a sarcomere stretch. It causes a overlap between the actin and myosin. But here what's happening? It is causing a ventricular dilatation. So whenever there is a ventricular dilatation, there is a back congestion. So there is a pulmonary congestion. So left heart failure. This is a left heart failure. Whenever there is a pulmonary congestion, the person becomes breathless. So heart failure treatment. This is heart failure can be given as a clinical case for you. That's why I added this. Once they have given this, treatment is diuretics, nitrates. So why does the diuretics give? The diuretics will remove the congestion. Nitrates will reduce the preload. So relief of congestion. In hemorrhage, there is a decrease in the venous return. Hypovolemic shock. In hypovolemic shock, there is a decrease in the venous return. There is a decrease in the preload. There is a decrease in the cardiac output. So remember, here preload is filling pressure. Understood? Preload is the pressure which is caused by the filling of the heart. So what did you understand till now? The end-diastolic volume up till a particular level is dependent upon the preload. Preload is dependent upon the venous return. So if it is within physiological limits, the sarcomere stretch will be causing an actin-myosin overlap, which will be causing an increase in the force of contraction, which will cause the stroke volume. I'll be showing this as graphs now. Okay. Whereas afterload, what is the meaning of afterload? I told you is the resistance of the left ventricle, which it has to overcome to eject the blood. I told you, isn't it? When the ventricle is contracting, it has to overcome the resistance of the aorta. So essentially, the pressure it faces during systole, it is largely determined by the systemic vascular resistance. That means the blood pressure. Whenever the blood pressure is increased, either hypertension, aortic stenosis, there is an increase in the afterload. Whenever there is an increase in the afterload, it causes a decrease in the stroke volume. I think you understood this. Afterload means it is the pressure which the ventricle has to overcome. So whenever that pressure is more, the stroke volume will be less. There is a decrease in the cardiac output. So in heart failure, afterload reduction with ACE inhibitors or nitroprusside dramatically improves the cardiac output. So remember, I told you Frank-Starling's law only is within the physiological limits. When it crosses the physiological limits, like it happens in heart failure, you have to keep using the drugs. The last part I told you is contractility, inotropy. What is inotropy? Intrinsic ability of the myocardium to contract independent of preload and afterload. That means, in spite of the preload and afterload, the heart can contract by itself. Why? Because it has the property of contractility. I think properties of the cardiac muscle is also an important question for you. It can be asked as a 5-mark question. Understood? The electrical property, contractility, everything you have to write. Okay. So positive inotropes will increase contractility. So what are the positive inotropes? What do you mean by positive inotropes? The inotropes which help in the contraction, which increase the contraction, are called positive inotropes. Catecholamines. What are they? Adrenaline, noradrenaline. Then digoxin. Digoxin is given in heart failure also. Digoxin, dopamine, dobutamine. Okay, so pharmacology people, remember this: catecholamines, digoxin, dopamine, dobutamine, which is used in cardiogenic shock and acute heart failure. These are used in cardiogenic shock and acute heart failure. Negative inotropes decreases contractility. For example, beta blockers, calcium channel blockers, acidosis, hypoxia, myocardial infarction. All this will cause a decrease in the contractility. In myocardial infarction, a part of the muscle is necrosed. So that's why it will not be contracting properly. So beta blockers, calcium channel blockers, acidosis, hypoxia. So contractility shifts the fan curlings upward. So this is the, I'm telling you, see, you have this curve. On the x-axis, you have the preload, end diastolic volume. On the y-axis, you have the stroke volume. So you are seeing here up to a certain level, here, an increase is causing an increase in the stroke volume. But after some time, there is a plateau because here the maximum number of actin and myosin are overlapping. After that, it cannot overlap. So too much stretch will cause a decrease in the contractility. Okay. The heart pumps what it receives. The stroke volume increases in response to the increase in the ventricular end diastolic volume. I told you preload. The key concept, increase in the venous return causes an increase in the end diastolic volume, causes an increase in the sarcomere stretch, causes an increase in the force of contraction, causes an increase in the stroke volume. So what is the optimal sarcomere length? 2 to 2.2 micrometers. Optimum sarcomere length means the maximum number of actin and myosin will be overlapping. After this, what will happen? The force will decline. That means it will start getting down. Clinical aspect. So you can see here, these are the three. When it is good, preload is good. When it is less, and when it is still less. So this is the atrial pressure. Preload, that's the cardiac output. Okay, slowly the cardiac output is decreasing. So heart failure, failing ventricle. See, this is given for ECFMG exam also. This is a very famous graph which is given in many MCQs. It is given in very MCQs. Okay. Heart failure. Failing ventricle operates on a depressed Starling curve. So the lower one, you can see the failing ventricle. That means there is a reduced stroke volume despite elevated preload. So the preload is increasing, but the cardiac output is not increasing because the stroke volume is not increasing. Why? Because the compensatory mechanism, ventricular dilatation, initially maintain cardiac output, but ultimately worsens outcome. In the beginning, there is a small dilatation, but in the end, it becomes more and more dilated. The actin and myosin will not be functioning properly. For you to understand, in exercise, see nowadays, one of the common questions which is being asked is, explain the cardiorespiratory changes in exercise. This can come in first or second paper. Understood? It is asked as an integrated physiology. It is asked as a integrated physiology. During exercise, venous return increases. Okay. End diastolic volume increases. Stroke volume is increasing. That means the ascending limb of the, here you can see here, this is the ascending limb. Sympathetic activation shifts the curve upwards, allowing greater cardiac output at the same preload. Though there is the same preload, the inotropic effect is more. Understood? So the preload not only causes an increase in the cardiac output, here there is also an increase in the inotropic effect of the heart because of the sympathetic stimulation. So this is the clinical application. So briefly, I'll be telling factors increasing cardiac output: sympathetic stimulation, epinephrine, norepinephrine will increase chronotropicity, inotropy, raising both the heart rate and stroke volume. Then exercise and physical activity, skeletal muscle pump. I think the diagram is also there. Skeletal muscle pump enhances venous return. So increases preload. Frank-Starling mechanism. Increases stroke volume. Okay. Fever and thyroid hormones. So fever also increases the metabolic demand. Thyroid hormones also increases the metabolic demand. So it causes tachycardia. So this causes an increase in the cardiac output. See, remember, up to a certain extent, an increase in the heart rate can cause an increase in the cardiac output. I'll be telling it to you next time. So key hormonal factors are epinephrine, norepinephrine, which increases not only the heart rate, it also increases the contractility. Thyroxine, metabolic demand is increased, so it increases the heart rate, increases the stroke volume. Then glucagon increases cyclic AMP, it increases contractility. Remember, glucagon is given, people who are about to write pharmacology, glucagon is given when anaphylactic shock will not be responding to doses of epinephrine. See, what is the drug of choice for anaphylactic shock? Epinephrine. Suppose you are given epinephrine first time, it is not responding. You are giving it for a second time, it is not responding. That means there is a refractory anaphylactic shock. Understood? What do you mean by refractory? That means the receptors are not functioning. So if the receptors are not functioning, you should always think about beta blockers. Perhaps the patient was a hypertensive, he was on beta blockers. So that's why though you are giving epinephrine, it's not functioning. That is the place where you give glucagon. So this you remember. It's an MCQ. In refractory anaphylactic shock, that means you are given 2 doses of epinephrine, it is not functioning. The drug of choice is glucagon. Insulin, very high dose, causes a mild positive inotropic effect. Okay. So any factor which causes an increase in the heart rate or stroke volume will cause an increase in the cardiac output. Factors decreasing parasympathetic stimulation. I think all of you know, vagal tone will cause a decrease in the heart rate. Myocardial damage, I told you, myocardial damage will not be allowing the optimum overlap of the actin and myosin, so it causes a decrease, like what happens in cardiomyopathy, myocarditis, myocardial infarction, all that. Arrhythmias, I told you about atrial fibrillation. What happens in atrial fibrillation? I told you there is a loss of the atrial kick. What is the atrial kick? 20% of the end diastolic volume is formed by the contraction of the atria in the last part. Understood? So this does not happen in atrial fibrillation. So this atrial kick will reduce the, it will not be happening. So it reduces the end diastolic volume. Ventricular tachycardia. See, there is something called supraventricular tachycardia. That means the heart rate is more than 120, 130. When this happens, the heart is beating so fast that it has no time to fill. Understood? From 60 to 100, though the heart is beating fast, it has time for diastole. But once it crosses 120, it will not be having time to fill because the diastole is very, very small, very, very short. So there is an increase in the systole, 120. So there is a decrease in the preload because there is a decrease in the venous return. So the stroke volume will reduce. Okay. And in heart block, see, heart block, many of you are answering wrong. What is heart block? It is not the blockage of the coronary vessels. Remember that. Heart block is a abnormality in the conductive system of the heart. See, normally, how does the conducting system work? From the SA node, it goes to the atria, it goes to the AV node. From the AV node, it comes to the bundle. From the bundle, it comes to the left branch, right branch. Then it goes to the Purkinje fibers and the ventricles are depolarized, isn't it? This is a normal way. But suppose there is a problem with the AV node. Understood? This electrical activity is not able to cross properly. That causes the first degree, second degree, and third degree heart block. Many of you are getting confused with this. So heart block is not a obstruction to the coronary artery. Understood? Heart block is an obstruction to the electrical activity of the heart. So first degree heart block, second degree heart block, and third degree. See, remember, heart block is also a short notes. Understood? They will give you, explain a normal ECG, waves of a normal ECG, and add a note on heart blocks. So please go through that heart block also, important. So finally, what you have to remember, any factor reducing preload, contractility, or causing severe bradycardia will decrease cardiac output. Is it clear? The bradycardia has to be severe. Even if it is mild bradycardia, it's not a problem. When it is severe, when it goes below 50, then it will cause a decrease in the cardiac output. So when does that severe bradycardia happen? When there is a heart block, third degree heart block, second degree heart block, they go into cardiac arrest. Okay. Then the neural regulation, sympathetic and parasympathetic. I told you the same things. Okay, I'll be talking to you this in the later on. Hormone regulation, catecholamines, thyroid hormones. I told this. So now, finally summarizing the whole thing, what is cardiac output? It is the amount of blood which is sent out by each ventricle per minute. Understood? So what is the formula? Heart rate into stroke volume. What is Frank-Starling's law? Within physiological limit, the force of contraction depends upon the initial stretch or the initial length of the muscle, cardiac muscle. So what is the cause of the initial length? End-diastolic volume. What is end-diastolic volume? The volume of blood which is present at the end of diastole just before the systole. Why is there an increase in stretch and increase in force of contraction? Within physiological limits, the stretch will be causing an optimum overlap of the actin and myosin fibers, which causes the increase in the force of contraction. So this causes an increase in the stroke volume. So what are the key regulators of the cardiac output? Preload, afterload, contractility, heart rate. Most important are preload, afterload, and contractility. Heart rate only if there is a severe bradycardia. Preload depends upon what? Venous return, blood volume. If the blood volume is low, like what happens in hypovolemic shock, then the stroke volume will reduce. When the venous return increases, like for example, I told you about the skeletal muscle pump also, which causes an increase in the venous return. Afterload. What is the afterload? Tissue, total peripheral resistance. That means the hypertension, which causes a increase in the resistance. Aortic pressure is increased when there is an aortic stenosis. So the heart has to pump the blood against more resistance, so the stroke volume will reduce. Contractility, sympathetic nervous system, catecholamines. I gave you some more things which cause an increase in the contractility. Heart rate, autonomic nervous system, ions and temperature. And also I told you about metabolic rate which is increased, like for example, thyroid hormones. All this will cause an increase in the heart rate. Okay. See, remember, hyperthyroidism. Okay. One of the most important clinical signs of hyperthyroidism is sleeping heart rate. See, what should happen to the heart rate when a person is sleeping? It should reduce. But in a person with hyperthyroidism, he will be having a tachycardia even in his sleep. This is a very notable clinical sign. Understood? Sleeping pulse rate or a sleeping heart rate is increased in hyperthyroidism. So when you're talking about the eyes and heat intolerance, all that, you also write about this one, sleeping pulse rate. That's very important. So normal cardiac output is 4 to 6 liters per minute. Cardiac index is 2.5 to 3.5 liters per minute. So this is we come to the last part. This is 10 minutes only. Baroreceptor reflex. I think all of you know short-term regulation of BP. Okay. So blood pressure regulation as a short-term and long-term. Some will talk about only short-term and long-term. Some will be telling short-term, medium-term and long-term. But all that is not needed. Short-term and long-term you can tell. Short-term regulation is neural regulation. Okay. So today what we'll be talking is the blood pressure regulation because of the baroreceptor reflex. So it is called a reflex regulation. Why is it called a reflex regulation? Suppose you are sitting, suddenly you stand up. What will happen to the blood? The blood will come and pool in the lower limbs. So if this reflex is not functioning properly, what will happen? The BP will fall. So U2 will fall. But are we all following when we are sleeping and then getting up? No. Why? Because of this regulation. Understood? This short-term regulation, because it has to be very, very fast, it is by the nerves. So that's why it's called a neural regulation or short-term regulation of blood pressure. So this is physiological process. That means it is maintained within the normal range, whether we stand, walk, sit, sleep, and again sit. All these changes of posture, it is neural regulation. It involves integrated neural, hormonal, and renal mechanisms. Total blood pressure regulation is an integration of neural, hormonal, and renal mechanisms. Okay. Today, mostly we'll be talking about only the blood pressure regulation by the baroreceptor reflex. The body constantly monitors and adjusts cardiac output, peripheral vascular resistance, and blood volume to ensure adequate perfusion to vital organs like heart, brain, and kidneys. So whenever there is a little decrease in the blood volume, like for example, some hemorrhage is there, what will happen? The heart rate will increase. Tachycardia is there. Understood? So whenever there is a decrease in the blood volume, vasoconstriction will happen. So all these are compensatory mechanisms. Baroreceptors. Baroreceptors are stretch sensitive mechanoreceptors. So remember, receptors, you have chemoreceptors, which are receptors for chemicals. Baroreceptors are there, which are mechanoreceptors. One more, can you tell me one more receptor which is mechanoreceptor? So these are stretch sensitive. Pain is also a mechanoreceptor. Chemoreceptor also is there. Touch is a mechanoreceptor. Okay. Located in the walls of the carotid sinus. So where is the carotid sinus? At the bifurcation of the common carotid artery and the aortic arch. See, one of the common mistakes you do is sinus and carotid body. You get confused with this. Carotid sinus and aortic arch. See, in the carotid sinus, the blood is there. This sinus will be having the mechanoreceptors. So it is sensitive to stretch. Whereas carotid body and aortic body are chemoreceptors. They will be helping in the chemical regulation of respiration. Remember that. Baroreceptors is for blood pressure regulation. Chemoreceptors are for respiratory regulation. So there it is carotid body, aortic body. Here it is carotid sinus, aortic arch. Okay. They detect changes in the arterial wall tension and transmit signals via the cranial nerve 9 and cranial nerve 10. See, in your practicals, you have to know all the cranial nerves. See, this time practicals I have seen some of you don't know the cranial nerves. When cranial nerve 1 is asked, you should know what is the test you have to do, isn't it? So you have to be thorough with the cranial nerves. Okay. Cranial nerve 9 is glossopharyngeal. Cranial nerve 10 is vagus. So whenever there is a reflex, remember, whenever in physiology you get a reflex, you have to write what is the stimulus, what is the afferent pathway, what is the efferent pathway, what is the center, okay, and what is the effect. So stimulus, afferent pathway, center, efferent pathway, and the response. These are the things that you have to write whenever you get a reflex. So here, what is the afferent pathway? Baroreceptors in the carotid sinus send signals via the glossopharyngeal nerve to the nucleus tractus solitarius in the medulla oblongata. So remember, NTS is read in the medulla. Then vagal efferents, aortic arch, baroreceptors transmit impulses via the vagus nerve. This also goes to the nucleus tractus solitarius. So ninth cranial nerve is taking the afferent signal. So what are the receptors? Receptors are stretch sensitive receptors. Understood? What is the afferent pathway? Two pathways. Afferent pathway through glossopharyngeal nerve, afferent pathway to the vagal nerve. What is the number of the glossopharyngeal nerve? Cranial nerve 9. What is the vagus? 10. Okay. Then you have the cardiovascular center in the nucleus tractus solitarius in the medulla, which receives all the afferent signals. It activates the caudal ventrolateral medulla. Caudal ventrolateral medulla, which inhibits the rostral ventrolateral medulla. These names you have to remember. The rostral ventrolateral medulla in some books is given as vasomotor center. So what happens? Nucleus tractus activates the caudal ventrolateral medulla, which inhibits the rostral ventral, the vasomotor center, thereby reducing the sympathetic output. So the sympathetic output is reduced, the blood pressure is reduced. For you to easily understand, whenever there is an increase in the stretch of the baroreceptors, when there is an increase in the stretch, then the blood pressure is increased. Whenever the blood pressure is increased, there is a stretch in the baroreceptors. What are the baroreceptors? Aortic arch and the carotid sinus. So from the carotid sinus, it goes through the cranial nerve 9. From the aortic arch, it goes to the cranial nerve 10 to the nucleus tractus solitarius. So the nucleus tractus solitarius, it activates the caudal ventrolateral medulla. What does this activation do? This inhibits the vasomotor center. When it inhibits the vasomotor center, the sympathetic activity is reduced. So when the sympathetic activity is reduced, there is a decrease in the blood pressure. Okay. So whenever the increase in BP, baroreceptors, this is what I told you. Dorsal ventromedial nucleus, there is an increase in the parasympathetic outflow. So two things are happening. One is the cardiovascular center is inhibited. Here there is a increase in the parasympathetic outflow, which causes a decrease in the heart rate, decrease in contractility. But remember, sympathetic is more than the parasympathetic. Response to low blood pressure, decrease in the blood pressure, reduces stretch, baroreceptors fire less, afferent signals decrease to the nucleus tractus solitarius, sympathetic outflow increases, and the parasympathetic decreases. Again, remember, parasympathetic action is less when compared to the sympathetic. Sympathetic activation, what does it do? It increases the heart rate, chronotropy, it increases sinotropy, it causes vasoconstriction, it increases the total peripheral resistance, and it restores the blood pressure. Efferent pathway is sympathetic, mostly sympathetic. Parasympathetic is less. So all this will cause an increase in the heart rate and vasoconstriction. Here you have to remember one thing. So whenever a baroreceptor reflex is asked, you have to write about the baroreceptor resetting. So what is a baroreceptor resetting? Adaptation to chronic hypertension. See, suppose a person is having hypertension. His blood pressure is always more than 140/90. If it is like that for 1 or 2 days, what will happen? These baroreceptors, which are normally accustomed to increase its response, will start firing at a higher pressure. So the set point is increased. So it will not be beating. So the person's blood pressure is always increased. Otherwise, I told you what will happen when there is an increase in the blood pressure. I told you whenever you are running or something, there is an increase in blood pressure, there is a compensatory mechanism. But here what's happening? The set point itself is increasing. See, all these are negative feedbacks. Understood? All these are negative feedbacks. That means when something increases, because of the negative feedback, it reduces. Or if something reduces, because of the negative feedback, it will increase. So what are the examples of positive feedback? See, feedback is also an important question for you. Homeostasis, positive feedback and negative feedback. Positive feedback means for you to write, remember, blood clotting and delivery. Okay. Oxytocin or milk ejection reflex. All these are positive feedback. Whereas here it is negative feedback. So resetting explains why baroreceptors do not correct the chronic hypertension. They adapt to sustained high BP, making them ineffective as long-term BP regulators. A critical concept you have to remember. Okay. So increase in the BP, baroreceptors, carotid and aortic activated, afferent cranial nerves 9 and 10. See, I'm repeating this so many times because it has to be written in your mind. It has to be written in your brain. Understood? This you cannot make a mistake. These are all very simple things. You should never make a mistake. Parasympathetic, what does it do? Decreases the sympathetic, decreases the heart rate, decreases contractility, vasodilation. See, sometimes orthostatic hypotension is given. Understood? As a 3 marks. See, orthostatic hypotension means failure of baroreceptors to compensate for the sudden postural changes. Understood? I told you what happens when you suddenly stand. There is a baroreceptor reflex and it is corrected. But suppose the patient is diabetic or suppose the patient is very old. What will happen? The autonomic nervous system is dysregulated. What happens? The autonomic nervous system is dysregulated. That means it will not be functioning properly. So the sympathetic and parasympathetic will not be functioning properly, more so the sympathetic. So when a person stands up suddenly, what will happen? Instead of the BP getting regulated, it will suddenly fall because the blood has come to his legs. The stroke volume will reduce because there is a decrease in the venous return. Understood? So this is common in elderly and autonomic neuropathy of diabetics. So the patient will be having a syncope. Syncope means sudden loss of consciousness. He may be either dizzy or will be having a syncope on standing. So that's why old people, you have to advise them to not stand up suddenly. You have to ask them to sit from the sleeping posture and then stand slowly by taking the support of something. Okay. So even in the toilets, now they are putting handles near the toilet seat because suddenly if they stand up, they may fall. So that's why they hold it, stand up, stand for some time. After the blood pressure is regulated, then they can walk. Then one more thing about the baroreceptor reflex you have to remember is carotid sinus massage. See, I told you there is something called a supraventricular tachycardia. Supraventricular tachycardia, when it happens, you can reduce the heart rate by doing a carotid sinus massage. That means, remember, carotid sinus massage should not be done two together. On both the sides, you will not do together because otherwise you will be causing a cardiac arrest. Only on one side, the carotid sinus are massaged. When they are massaged, there is an increase in, I told you, carotid sinus causes a vagal activation, bradycardia, and the BP drops. Okay. So what you have to remember, baroreceptor reflex is a short-term regulation of blood pressure. Long-term control involves reticular activating, the renin-angiotensin-aldosterone system and renal mechanisms. Okay, then Bajol-Jarisch reflex is a 3 marks question for you. You go through it. Bainbridge reflex, 3 marks question for you. Go through it. Cushing reflex are also important variants. So these 3 reflexes also can be asked as 3 marks question. Bajol-Jarisch reflex because of the pain, Bainbridge reflex, and Cushing's reflex. Okay, when there is an increase in the intracranial pressure, what happens? Okay, these 3 are also important. So thank you very much for giving me this opportunity. I would like to ask any one of you, if you have any doubt, please write it in the chat box. I'll be trying to see it and telling it. Hope this was useful. I would like to have a feedback also from you.
Thank you, sir. If anyone has any doubts, you can either write it in the chat box or please raise your hands so that I can give you the unmute option.
I think NMO, if you see, I have given some, what do you call that, infographics also of these three topics.
Yeah, sir.
You can give it to the group. If you have a group of NMO, you
Yeah,
can give
sir.
it to the group so that it becomes easy for them to answer that question.
Oh, yeah, sir. Sure, sir.
And from next year, I think even after the first internal, second internal, because people from all over the country are joining, we can have a discussion of the papers of physiology, anatomy, and biochemistry. That will also be helpful in the long term, because now it's in the end, no? We can do it after every, what you call, internal exam. Collect all the papers, see what are the common questions which are being asked, and we can prepare answers also for you, and we can prepare a booklet also.
Yeah, sir. Yeah, sir. Those are some good ideas.
Yeah. Just think about it.
Yeah, sir. Sir, I don't think there are any questions. Chat box lo kuda em cheppatledu, and no one has also raised their hand. So I guess
Okay.
we can conclude the session, sir.
Okay. So chat box lo kuda em ledhu kada. Entamandi join ayyar idea unda?
Sir, total 42 members join here, sir.
Okay.
Yes.
Right.
Let us
Okay.
yes. Let us conclude this session with Shanti Mantram. Om Sarve Bhavantu Sukhinah Sarve Santu Niramaya Sarve Bhadrani Pashyantu Ma Kaschid Dukkha Bhag Bhave. Om Shanti Shanti Shanti. We extend our heartfelt gratitude to Dr. Srinivas Rao, sir, for an insightful and enriching session. Thank you, sir, for your valuable time, guidance, and unwavering support. We also thank all the participants for your enthusiastic presence and active participation. Thank you, everyone. The webinar will end now. Dhanyawad.
Okay. Thank you. Jai Shri.